Welcome to this deep dive, all geared up to help you totally ace your plastic surgery board exam.
We're diving deep into neck lifts today,
We're going to cover all the need-to-know info so you're ready for whatever questions they throw at you.
starting with the anatomy, of course.
You absolutely have to know the layered structure of the neck, like inside and out.
Absolutely. Starting with the most superficial,
Yeah.
we have the skin. Then just beneath that is the subcutaneous fat.
And under the fat, what's there?
You'll find the superficial cervical fascia.
Okay.
It's a thin layer, but it's important. It covers the platysma muscle.
The platysma, it's so key for neck contour, and it really guides how we approach rejuvenation procedures, right?
Yeah. And, it's continuous with the SMAS, which is a really critical point to remember when you're thinking about facelifts.
Gotcha. So deeper than the platysma, what do we have?
Deeper, that's where the subplatysmal structures are.
Okay.
More fat there, the digastric muscles, and the submandibular glands.
All right. And then finally at the deepest layer.
We have the deep cervical fascia, a tough layer.
Okay.
It encloses that sternocleidomastoid muscle and attaches to key structures like the hyoid bone. Oh, and the ligamentum nuchae.
All right. Let's shift focus to the platysma muscle. What's important about that?
Well, it originates from the pectoralis and deltoid fascia, and its anterior fibers they insert on the mandible.
Okay, so what about the posterior fibers?
They cross over the mandible and attach to the SMAS, which again highlights that connection we talked about earlier.
Yeah. So for the exam, you're going to need to know the platysma's blood supply and the innervation.
Right. So it gets its blood from a branch of the submental artery.
Right.
And the nerve supply comes from the cervical branch of the facial nerve.
What happens if we injure that nerve during surgery?
You can get pseudomarginal mandibular nerve paralysis. It's pretty easy to confuse it with true marginal mandibular nerve paralysis.
How do you differentiate them?
Ask the patient to purse their lips. In both cases, you'll see weakness when they try to lower their lip, but if they can't purse their lips at all, then that's true marginal mandibular nerve injury.
So big picture, what does the platysma actually do?
Its main job is pulling down on the lower lip and the corner of the mouth. It's also responsible for those oblique wrinkles we see in the aging neck.
And the platysma, it has different decussation patterns, right? And these variations affect the neck's contour.
Right. Most common is type 1.
Type I, okay.
There's partial decussation at the midline.
Okay. And what are the other types?
Type 2 shows total decussation, and in type 3, the fibers don't interdigitate at all.
So why is type 3 significant from a surgical standpoint?
Because, without that support from the decussation, you're more likely to see those vertical bands in the neck.
All right. Moving on to the nerves, what should we really be mindful of during any neck procedure?
Well, the cervical nerve branches and the marginal mandibular nerve for sure. The cervical branches, they run under the platysma, while the marginal mandibular nerve is in the submandibular triangle.
And that nerve is particularly vulnerable during surgery, right?
Yes, especially within that 2-centimeter radius circle, 2 centimeters behind the corner of the mouth.
Okay.
You really want to avoid electrocautery in that area.
Yeah, definitely the danger zone. So why is electrocautery there such a bad idea?
Because the current can travel along the tissues and directly damage the nerve.
Gotcha. So another nerve we need to be aware of is the great auricular nerve,
Oh.
the JN.
Right. It comes out from under the sternocleidomastoid muscle, crosses over it, and runs with the external jugular vein.
And what are the consequences of a JN injury during surgery?
You could end up with sensory problems, like lower ear, the nearby neck skin, even the cheek.
So really emphasizing that careful suture placement in that area.
Exactly. We don't want to compress or entrap the nerve.
Gotcha. All right, next up, let's talk about the submandibular glands. Where are they located?
They're in the submental triangle. The facial artery runs right along their upper border.
And the marginal mandibular nerve, where is that in relation to the gland?
It passes close to the glans capsule. It's just another layer of complexity when you're doing procedures in that area.
Sometimes we have to remove the superficial lobe of the submandibular gland.
Yes, but we have to be incredibly careful there.
Why?
There's a high risk of damaging nerves and blood vessels.
So what's the preferred technique?
Infracapsular resection, you stay within the glans capsule.
Makes sense.
But even then, there have been cases of serious bleeding after resection.
Oh, wow.
So this procedure should only be done by really experienced surgeons.
Now let's turn our attention to the digastric muscles. Tell me about those.
Sure. Each digastric muscle, it has 2 bellies connected by a tendon.
And they're actually innervated by different cranial nerves.
That's right. The anterior belly is innervated by cranial nerve 5, while the posterior belly gets its innervation from cranial nerve 7.
How do we approach the digastric muscles during neck rejuvenation?
We might do a partial excision or shave down the anterior belly a bit just to refine the cervicomental contour.
Gotcha. Okay, let's talk about retaining ligaments. What are those?
Retaining ligaments, those are fibrous structures that support facial tissues. As they weaken with age, we start to see those classic signs of aging.
Which retaining ligament is the most important for us to know?
The mandibular cutaneous ligament. It goes from the mandible to the dermis. And remember, the marginal mandibular nerve is right nearby.
Okay.
And then there's the mandibular septum. This one extends back from the mandibular cutaneous ligament
Okay.
and sits near the jowl fat. We have to keep it in mind when addressing jowling.
Now let's focus on the fat compartments.
Yeah.
What are the different fat compartments in the neck and face?
We need to know the jowl fat, the supraplatysmal fat, the subplatysmal fat, and the 5 periauricular fat compartments.
Okay, can you break those down a little?
Sure. The jowl fat, that's the lowest facial fat compartment, while the supraplatysmal fat sits above the platysma muscle.
And the subplatysmal.
That lies beneath the platysma. Got to be careful of the anterior jugular veins when working in this area.
Okay. And the periauricular fat compartments, what about those?
Those are really important when we're doing facelifts. Oh, and remember the subauricular membrane.
Okay.
It separates the inferior and subauricular compartments, and it's closely associated with that great auricular nerve.
So, shifting gears to preoperative assessment, what do we absolutely have to do before even thinking about neck rejuvenation surgery?
Get a thorough medical history.
What are we looking for specifically?
You want to pay really close attention to things like hypertension and smoking status.
Why is hypertension so important?
Because if it's not well controlled, the risk of hematoma after surgery goes way up.
Okay. And smoking.
Huge red flag. Dramatically increases the risk of skin necrosis, which is a devastating complication.
Gotcha. And we also need to evaluate the patient's skin, right? What are we looking at there?
Yeah, so its quality, how elastic it is, and how much excess skin there is.
And skin elasticity, that's a big factor in how we approach the surgery, isn't it?
Yeah, absolutely. Patients with good skin elasticity might be candidates for less invasive stuff,
Like,
like liposuction.
okay, and if they have poor elasticity with a lot of excess skin,
Then they'll likely need a full neck lift with incisions around the ears.
okay. So what else are we assessing during the pre-op?
Fat distribution, how prominent the platysmal bands are, and the size of the digastric muscles.
Anything else?
We also check for submandibular gland aposis, how the chin projects, and look for any problems with the cervical spine.
Chin projection. That's an interesting one. How do we know if a patient might need a genioplasty?
Well, if they've always hated their chin, then a genioplasty might be something to consider.
But if their main concern is the neck, and they haven't had issues with their chin before,
Then neck surgery alone might be enough to address their concerns. You know, although sometimes an alloplastic chin implant or an osseous genioplasty, that can really make a difference in those neck contours.
and the cervical spine, why is that relevant?
Because, you know, if they have arthritis in the cervical spine, it can change the position of neck structures, and that can create extra skin redundancy.
Before we move on to the surgical options, let's quickly go over the visual criteria of a youthful neck. What are we looking for?
Okay, so a well-defined inferior mandibular border, a visible subhyoid depression, and you should be able to see that thyroid cartilage bulge.
Okay, anything else?
The anterior border of the sternocleidomastoid muscle should be visible, and ideally that cervicomental angle should fall between 105 and 120 degrees.
Perfect. All right, let's dive into the different options for neck rejuvenation. What are our surgical and non-surgical approaches?
Surgically, we can do liposuction alone, a submental neck lift, an isolated neck lift, or a full face and neck lift.
Okay, are there any procedures that we can do in addition to those to make the results even better?
Yeah, genioplasty, buccal fat pad removal, skin resurfacing, those can all play a role.
And on the non-surgical side, what are our options?
We have microfocused ultrasound, botulinum toxin injections, and deoxycholic acid injections.
So how do we decide which approach is the best for each patient?
It all depends on their needs and anatomy.
So for instance, if a patient has a lot of skin laxity,
Surgical correction is usually the way to go.
okay, and what if there's a lot of jowling?
A facelift is usually needed along with the neck lift.
Got it. And if there's no jowling and minimal skin laxity?
Non-surgical options might be enough to get them where they want to be.
Okay. So let's get into the specifics of some surgical techniques, starting with liposuction.
Liposuction is a great option for younger patients.
Why is that?
Well, they usually have good skin quality and localized fat deposits.
Okay. What's important to remember about the technique itself?
We use a wetting solution with epinephrine, lidocaine, and saline, and we choose different cannulas depending on the area we're treating.
So where do we usually make the incisions for liposuction in the neck?
Typically in the submental area or behind the earlobes.
Are there any modifications to this standard liposuction technique?
Yeah, we can do ultrasound-assisted or laser-assisted liposuction
When would we do that?
if we need more skin contraction.
What about drains? Do we use them?
Not usually if we're only doing liposuction.
Post-operatively, what do we do?
The patient wears a compression garment to minimize swelling and help contour the tissues.
What's a common mistake people make with liposuction in the neck?
Taking out too much fat?
Oversuctioning.
Yeah, if we remove too much, we can end up with contour irregularities.
So better to err on the side of caution.
Yeah, it's better to leave a thin layer of fat to avoid scarring and maintain a natural look.
Gotcha. Anything else we need to be on the lookout for after liposuction?
Sometimes platysmal banding that wasn't noticeable before might become apparent after the fat is removed.
Okay.
So we have to be prepared to address that.
All right, now let's talk about this submental neck lift.
That's a good option for patients who need correction of platysmal banding.
And who else might be a good candidate?
Patients with good skin tone and maybe some excess skin, but who want to avoid a longer incision around the ear.
So where do we make the incision for a submental neck lift?
Just behind the natural submental crease.
Why there?
It hides the scar well and gives us great access to the platysma for plication.
What else can we do during a submental neck lift?
You can remove excess fat
From where?
from the subplatysmal and subcutaneous layers.
But there's something we have to be careful about, right?
Yes, we have to preserve enough subcutaneous fat to avoid creating a submental depression.
Gotcha. What if the patient also has gelling?
We can release the mandibular septum and ligament through the same incision.
Okay. Are there any other procedures we can perform through that submental incision?
We can do a partial resection of the anterior belly of the digastric muscle or an intracapsular submandibular gland resection.
Yeah.
But procedures carry additional risks, and you have to really consider them carefully. It's crucial to talk those risks over with the patient before you do anything.
Gotcha. What about drains?
We usually put a drain in if we remove part of the submandibular gland.
Okay. What are the potential complications we need to discuss with the patient?
Bleeding, nerve injury, dry mouth, salivary fistula, those are all possibilities.
All right. Let's talk about the isolated neck lift now.
Isolated neck lift is a good choice for patients who have excess skin and poor elasticity but don't need a full facelift.
Where do we make the incision for an isolated neck lift?
It goes from the tragus behind the ear to the retroauricular sulcus. It might extend into the hairline.
Okay, what are the benefits of that approach?
It effectively targets the jowls and neck without needing an incision above the tragus.
Which you would in a facelift.
Exactly.
And we combine this with other incisions.
Yeah. Adding a submental incision can help us address platysmal banding more effectively. It also prevents it from coming back.
Let's move on to the short scar face and neck lift.
That one's suitable for patients with mild jowling, a little bit of excess cervical skin, and good cervical skin elasticity.
Okay, why is skin elasticity so important for this technique?
Because it really depends on the skin's ability to retract and tighten after we lift the tissues underneath.
And these patients typically?
They want a smaller scar.
Okay, that makes sense. Where do we make the incision for the short scar face and neck lift?
Below the sideburn, either preauricularly or retrotragally, we may also add a submental incision.
So how do we do the neck contouring with this technique?
We can use liposuction or a submental approach.
When is the submental approach especially helpful?
When we need to address platysmal banding, jowling, or moderate skin laxity.
Okay. Can you walk us through the basic steps of this procedure?
Sure. First, elevate the skin flap. Then we dissect and lift an SMAS platysma flap. We do a lateral SMASectomy and platysmal resection. And then we plicate the SMAS platysma flap to the mastoid fascia.
Okay. What's the downside to this technique?
The results in the neck may not last as long as a full face and neck lift.
Okay. Finally, let's talk about the full scar face and neck lift. Who is this the gold standard for?
This is for patients with significant skin laxity and jowling. They usually need their mid-face addressed as well.
What makes this approach so comprehensive?
The incision allows for maximum skin excision and redraping.
Can you describe the incision?
Sure, it goes around the earlobe, up to the tragus or even higher and into the occipital hairline.
What are the key steps after making the incision?
First, we align the hairline. Then we take out the excess skin, and then we meticulously close the retroauricular sulcus.
What about fat removal? How do we do that?
We can do liposuction or direct excision depending on the surgeon's preference.
Why would a surgeon choose direct excision
Some surgeons believe it minimizes the risk of contour deformities.
compared to liposuction?
Yeah.
Now that we've covered the surgical options, let's talk about the non-operative techniques, starting with microfocused ultrasound, also known as Ulthera.
Ulthera uses focused ultrasound energy to heat the tissues. It causes them to contract and stimulates collagen and elastin production.
Which layers does it target?
It can affect the dermis or even the SMAS, all while sparing the epidermis.
Are there any downsides or limitations to Ulthera?
It works best on patients with a BMI under 30.
Okay,
Those with a higher BMI may not see as much of an improvement in skin laxity.
gotcha. Next, we have botulinum toxin, or commonly known as Botox.
Botox can be really effective for those platysmal bands.
What type of patient is a good candidate for Botox in the neck?
Someone with prominent bands but not much skin excess who's not ready for surgery yet.
Okay. Can it also be used after surgery?
Yeah, actually, it can help treat recurrent banding after a neck lift.
So how do we administer the Botox?
We inject about 20 units per band, spaced about 1 centimeter apart.
What are the possible side effects?
Dysphagia, edema, bruising, neck discomfort, and muscle weakness are all possible.
So who should we avoid using Botox on?
Patients with poor skin elasticity or a lot of submental fat,
Why?
because the results might not be visible and the risk of side effects is higher.
Finally, let's discuss deoxycholic acid injections, marketed as Kybella.
Kybella destroys fat cells. It's called adipocytolysis
Where do we inject it?
into the preplatysmal fat. We space the injections about 1 to 1.5 centimeters apart.
Okay. And what's a crucial landmark we need to keep in mind?
We have to stay at least 1 to 1.5 centimeters away from the mandible.
Why?
You don't want to injure the marginal mandibular nerve.
Okay. How many treatments do most patients need?
Most need multiple treatments, usually about a month apart.
How many treatments before we start to see results?
Most patients see improvement after 2 to 4 treatments.
Okay. What about side effects?
Pain, bruising, swelling, and temporary marginal mandibular nerve weakness are all possible.
Are there any contraindications for Kybella?
Absolutely. We should not use it in patients with preplatysmal bands. Or skin laxity, a history of segmental surgery, dysphagia, facial nerve paralysis, or an active infection in the area.
All right, now let's get into the specifics of the operative techniques for neck rejuvenation. Let's start with skin flap procedures.
Okay, so with skin flaps, you need wide undermining for proper redraping. And you want to preserve at least 3 millimeters of subcutaneous fat.
And the subauricular membrane, what do we do with that?
Releasing it posteriorly can help prevent banding.
How do we redrape the neck skin?
We use a posterior and diagonal vector. That way you get a natural contour.
And that's different from how we redrape facial skin.
Yeah. Facial skin is redraped superiorly.
Okay, so what if we have a patient with a really severe turkey gobbler deformity?
In that case, the Cronin and Biggs TZ incision technique can be really effective. It does leave a more noticeable scar, though.
Why is that technique so useful?
It helps to restore that youthful cervical angle.
What type of patient might benefit from this technique?
Those who've lost a lot of weight, they tend to have a lot of excess skin.
Gotcha. Next up, let's talk about platysmal procedures.
There are several ways we can work with the platysma. We can do imbrication, clotation, incision lengthening, or suspension.
Okay, let's start with medial platysma techniques. What are those?
If there's diastasis or separation of the platysma muscles, we plicate the medial borders.
Okay, if we're also doing a facelift, what then?
We need to fixate the SMAS before we plicate the platysma. That way we make sure we get maximum lift in the cheek area.
Okay, and the corset platysmoplasty, that's a pretty popular technique, right?
Yeah, it's a good one.
Yeah.
It's great for addressing those static paramedian muscle bands and shaping the neck and flattening the segmental plane.
How does it work?
We fold the extra muscle inward, creating a midline seam.
What's the advantage of doing it that way?
We don't actually have to remove any muscle.
Okay, where do we make the incision for a corset platysmoplasty?
In the submental area.
Okay, and how far down do we plicate the muscle?
All the way down to about 3 finger breadths above the suprasternal notch.
Okay, and what kind of sutures do we use?
You want to use crisscrossing and backtracking sutures.
Why those?
They create a really tight seam. And you can add submandibular running mattress sutures if you need to address any remaining laxity.
So the corset platysmoplasty is really effective for.
Recontouring the submental area.
Got it. Can we combine that with other techniques?
Absolutely. Combining it with lateral pletition can really define the jawline and improve that neck-jaw angle.
Okay, now let's talk about lateral platysma techniques.
Releasing the platysma inferiorly can give you more lateral movement during pletition.
How do we release it inferiorly?
We excise a wedge of muscle at its lower attachment.
Got it. And what about a platysma flap?
You can elevate a platysma flap through a small incision near the angle of the mandible,
Okay.
and then we can put in suspension sutures.
Where do those go?
They go between this platysmal window and the mastoid fascia. It helps enhance the contour of the lateral neck.
Okay. Another technique is the platysma flap cervical rhytidoplasty.
Right, with this one, you do a sectional myotomy of the medial platysma edge.
And what does that myotomy allow us to do?
Well, it allows us to rotate and advance the flap edges laterally, and then we suture them to the mastoid fascia
Where should we do the myotomy?
at the level of the cricoid cartilage.
What if we go lower?
You can end up masculinizing the neck.
Okay. Let's wrap up with suspension sutures.
Suspension sutures can be used in a few different ways to refine the neck contour.
Okay. Like how?
Well, for example, sutures running along the lower border of the mandible over the platysma's superficial fascia can help define the jawline.
Okay. How do we place those?
We can interlock them at the midline and tack them to the mastoid fascia.
Okay. Anything else we can use suspension sutures for?
We can use them to support enlarged or prolapsed submandibular glands or to enhance the neck-jaw angle.
Are there any modifications to this technique?
Yeah, we can add a horizontal platysma plication below the submandibular gland.
What does that do?
It further addresses contour issues.
So let's move on to some adjunctive procedures that can be performed during neck rejuvenation surgery.
Sure.
What about direct defatting?
Direct defatting in the subplatysmal plane can remove those stubborn fat deposits that liposuction just can't get.
And what about if the submandibular gland is prominent or apoptotic?
We might need to take it out.
To prevent what?
To prevent it from becoming more noticeable after the cervicoplasty,
Okay. Are there any alternatives to removing it?
you can inject it with botulinum toxin.
And why would we do that?
It'll reduce its size and make it less prominent.
Okay. What about the digastric muscle?
If the anterior belly is super hypertrophied, we might choose to partially resect it.
And finally, what about a genioplasty?
A genioplasty can really improve the neck's appearance for patients with microgenia, a small chin.
Excellent. Now that we've talked about all the surgical techniques, let's talk about postoperative care for neck rejuvenation procedures.
Before we even close, we have to make sure the patient's blood pressure is back to normal and that we have really good hemostasis.
Why is hemostasis so important?
It minimizes the risk of hematoma.
And what about blood pressure postoperatively?
We need to watch it closely. We might use meds like beta blockers or alpha agonists to prevent bleeding.
What about positioning?
Patients should avoid pillows that flex their neck.
Why is that?
We want to keep that cervicomental angle open
To prevent what?
to prevent skin folds that can block lymphatic drainage.
What about drains?
Whether we use drains or not, that's up to the surgeon.
But if we do use them, when do we take them out?
Usually on the first day after surgery,
After we've done what?
after examining them, of course.
What about dressings?
We use a compression garment, or dressings,
To do what?
to help absorb any fluids and minimize swelling.
Okay. And on the first post-op day, what do we typically do?
We usually switch out the operative dressing for a neck strap.
How long do they wear that?
For up to 4 weeks,
When can patients shower and wash their hair?
after 24 to 48 hours, it's important to keep the incisions clean.
What about activity? Are there any restrictions?
Yeah, they need to avoid strenuous activity for about 6 weeks.
Okay. And when can they usually get back to their normal routine?
Most patients can start easing back into things over 2 to 4 weeks.
Anything else we should tell them about post-op?
They might experience some firmness in the tissues or the scar areas for up to a year.
Is that normal?
Yeah, it usually goes away on its own.
And what if it doesn't go away or it bothers them?
We can treat it with massage, ultrasound therapy, or steroid injections.
Now, let's talk about potential complications.
Sure.
Starting with hematoma. What is a hematoma?
It's a collection of blood. It can form after surgery.
How common are they?
The overall rate is about 3% in women and 8% in men. Hypertensive patients are at increased risk.
Why are hematomas such a big deal?
Large hematomas can be life-threatening. They can compromise the airway and the viability of the skin flap.
And what about if it's smaller?
Even small ones can lead to scarring, so you have to drain them right away.
What can we do to prevent hematomas from forming?
Meticulous hemostasis during surgery is key, and careful blood pressure management post-op.
Okay, another potential complication is a seroma. What's that?
It's a collection of fluid.
What do we usually do if a seroma develops?
We usually aspirate it over and over until it goes away.
Okay, and if it keeps coming back?
We might need to put a drain in or inject a sclerosing agent just to close that dead space.
Okay, let's talk more about marginal mandibular nerve injury.
Okay.
It's a very common nerve injury after neck lifts, right?
It is, yeah. Usually presents as weakness of the lower lip depressors. Makes it hard to lower that bottom lip.
What's the usual cause?
Most cases are due to neuropraxia.
Which is?
It's temporary nerve damage from traction during surgery.
How long does it usually take for neuropraxia to resolve?
It typically gets better on its own within 3 months.
What's the best way to manage it?
Most cases just need conservative management, like observation and reassurance.
But what if it doesn't go away?
Then we might have to investigate further. We might even need to do surgical exploration.
And who would we refer them to?
A peripheral nerve specialist might be helpful.
Okay, moving on to silosyl. How do we manage that?
Usually we can manage that non-surgically.
What are our non-surgical options?
Pressure dressings, aspirations, and botulinum toxin injections.
Why botulinum toxin?
It can temporarily paralyze the affected salivary gland.
What if those don't work?
Then we might have to operate
To do what?
to fix the underlying issue, like a damaged salivary duct. We might ligate it.
Okay, let's talk about skin necrosis.
Okay.
It's a serious complication. What are the key things we need to do to manage it?
We have to debride any necrotic tissue, provide local wound care, and maybe consider hyperbaric oxygen therapy.
What if there's a lot of skin loss?
If it's significant, we may have to do a skin graft or flap reconstruction.
Okay. And what about great auricular nerve injury?
That one usually comes from trauma during surgery.
And it causes?
Temporary numbness or tingling
Rare.
in the ear, scalp, or face.
How can we prevent this?
Careful dissection and knowing the nerve's anatomy really well.
Okay, what about contour irregularities? Can those be fixed?
Yeah, we can usually address them with secondary procedures.
Can you give us some examples?
Sure. Fat grafting can improve contour deformities from over-resection of fat.
Okay.
And if there's any residual fat, we can do liposuction or direct excision.
What's important to remember when doing liposuction in revision cases?
Scarring and altered anatomy can make it hard to get the fat out properly.
Okay, what about seromas and hematomas? Can they cause contour problems?
Yes, even small ones can cause skin indurations and contour problems.
How do we treat those?
Steroid injections can sometimes help, but prevention is key. Meticulous hemostasis and good drain management.
What if there's residual bulging from the anterior belly of the digastric muscle or submandibular gland ptosis,
Might need a secondary cervicoplasty to fix those.
which highlights the importance of?
Taking care of these issues properly during the first procedure.
Okay, what about residual platysmal banding?
That can happen because of excess skin, scar tissue, platysmal deaccusation coming back, or fluid collections.
What can we do to prevent that?
Getting rid of those hematomas and seromas quickly is really important.
Okay,
Compressive dressings, like a chin strap, can help too.
to minimize dead space.
Exactly.
So how do we treat it?
We can try steroid injections, scar massage, ultrasound therapy, or even botulinum toxin injections.
And when is a revision surgery necessary?
In really bad cases, but it's harder because of the scar tissue.
Okay, let's talk about recurrent jowling. That can be frustrating for both the patient and the surgeon.
It can. It can happen if the skin redraping isn't done well, failure to release the mandibular ligament, contour irregularities, submandibular glanditosis, or radial expansion of facial fat.
How do we manage recurrent jowling?
Depends on what's causing it. Could be liposuction, direct fat excision, or skin and SMAS redraping.
Okay, let's talk about the vertical band deformity.
That's when you have a single midline band going from the submental area to the lower border of the platysma.
What causes that?
Not releasing the skin from the platysma enough, over-tightening of the medial platysma, plication, or scar formation.
How do we treat it?
Reapproximate the medial platysma and release the skin to take the tension off.
Finally, let's talk about the timing of revision surgery. When should we do it?
Ideally, you want to wait at least 6 months, preferably 12, after the first procedure.
Why is that so important?
It gives the tissues time to heal and settle down so you get better results. And it lowers the risk of more complications. It lets the scar mature so it's more predictable when you operate.
Okay, now let's talk about a really important part of neck rejuvenation surgery, managing complications.
We've talked about some specific complications, but it's super important to do a good pre-op assessment and to be really meticulous with your surgical technique.
Prevention is key. How can we minimize complications?
Making sure you have good hemostasis throughout the procedure.
Okay.
That'll help reduce hematomas and seromas.
And how about nerve injuries and contour irregularities?
Handle the tissues gently, don't pull too hard, and be mindful of those anatomical landmarks. That's all really important.
Okay, so let's say a hematoma develops. What do we do?
You have to act fast.
What do we do?
Go back to surgery and get that blood collection out.
And what about to prevent it from happening again?
You have to find the bleeding and stop it.
And what about post-op?
You have to watch for any signs of hematoma, like more pain, swelling, and bruising.
Okay, let's talk about seroma management.
Seromas aren't usually as urgent as hematomas, but they can bother patients.
Yeah.
And they can slow down healing.
How do we typically take care of them?
Usually just aspirating them a few times is enough.
And if they keep coming back?
Then we might need to put in a drain or inject a sclerosing agent
To do what?
to close that dead space.
Okay, let's talk about marginal mandibular nerve injury again. It's a common worry for surgeons, isn't it?
It is. But most cases are temporary. They get better on their own.
So conservative management.
Yeah. You observe them and reassure them.
What do we tell them?
Just that the nerve will probably recover on its own.
And if it doesn't come back in a reasonable amount of time?
We might need to do more tests, maybe even explore it surgically.
Okay, who do we refer these patients to?
A peripheral nerve specialist can be helpful.
Okay, let's talk about silasala. How do we manage that?
A lot of times, non-surgically.
What are the non-surgical options?
Pressure dressings, aspirations, and botulinum toxin injections.
Okay, what if those don't work?
Then surgery might be necessary.
To do what?
Fix the underlying problem. Maybe the salivary duct is damaged. We might have to tie it off.
Okay, and skin necrosis.
You have to debride any dead tissue, take care of the wound, and consider hyperbaric oxygen therapy.
Okay, and if the skin loss is big?
Might need a skin graft or flap reconstruction to cover the defect.
What about contour irregularities? Can they be fixed?
We can try to fix them with secondary procedures.
Okay.
You can use fat grafting to fix contour problems from removing too much fat. And if there's still some fat left, we can do liposuction or take it out directly.
Okay. What about residual platysmal banding or recurrent jowling?
We might be able to fix those with revision surgery.
But
It's tougher the second time around, and we might not get perfect results.
so it's important to be upfront with the patient about.
The risks and limitations of revision procedures, you have to have that conversation before doing anything.
Speaking of talking to patients, what do we need to discuss before surgery?
You have to manage their expectations. Talk about potential complications and how long recovery will take.
Why is setting expectations so important?
It's key to keeping patients happy.
Okay. And post-op.
Emphasize how important it is to follow your instructions, like taking care of the wound, avoiding strenuous activity, and coming to those follow-up appointments.
Now let's talk about neck rejuvenation surgery in men, specifically.
Men usually have thicker skin and stronger platysmal bands than women.
So how does that change our surgical approach?
We might have to use more aggressive techniques to get the results we want.
Okay. What else do we need to be careful of in men?
The beard.
The beard, okay.
Yeah, don't shave too close to the incisions. You don't want an infection.
Yeah, the final result.
We want to keep that masculine neck contour. So don't over-resect the platysma and make sure you can still see the thyroid cartilage.
Okay. Now let's talk about patients who've had big weight swings.
Those patients, they usually have extra skin and poor elasticity. They're more likely to have complications. Seroma, skin necrosis, those kinds of things.
How do we manage those patients?
First, get their weight stabilized before even thinking about neck rejuvenation. And when we do surgery, maybe consider a more conservative approach, like liposuction alone or a limited neck lift.
To minimize tension on the skin flaps.
Exactly.
Okay. Let's talk about patients with pre-existing medical conditions, like diabetes or hypertension.
Those conditions can also increase the risk of complications, so we need to manage them carefully.
Okay. What do we need to be thinking about?
Make sure their blood sugar is under control if they're diabetic. And we need to make sure their blood pressure is well regulated if they have hypertension.
And post-op.
They might need longer to recover, and we need to watch them more closely.
All right. Let's step back and review some key points about neck anatomy and aging.
Sure. As we age, our necks change.
Okay.
We lose elasticity in our skin, we lose subcutaneous fat, and the platysma muscle relaxes. That all contributes to an older look.
Okay. And then there's gravity
Gravity definitely doesn't help, makes things sag, and we lose that sharp jawline.
and the retaining ligaments.
Those weaken too. That adds to the sagging.
What about bone resorption?
Yeah, especially in the mandible and hyoid bone. That changes the structure of the neck, and we have to factor that into our surgical plan.
Okay. So we really have to understand those age-related changes too.
Plan and perform neck rejuvenation procedures that are going to work.
Let's talk about those retaining ligaments again. Why are they so important in neck lift surgery?
They're like anchors holding the skin to the deeper structures. They provide support.
So when we're operating,
We have to release or move those ligaments around to get the skin to redrape properly. That creates a more youthful contour.
can you give us an example?
Sure, we often release the mandibular cutaneous ligament, the one near the jowl fat pad, to fix jowling.
And the platysma auricular ligaments.
Releasing those can really make the jawline and neck angle pop.
But we have to be careful, right?
Absolutely. If you release too much, the results can look weird. You could even injure a nerve.
Okay. Let's talk about some advanced techniques for neck rejuvenation. What about working with the SMAS?
The SMAS, that's the superficial musculoponeurotic system. It's a layer of connective tissue. It goes from the face down to the neck.
So how do we use it during a neck lift?
When we manipulate the SMAS, we can address deeper problems and get better results overall.
Okay. Can you give us some examples?
Sure. We can do a SMAsectomy. That means taking out a piece of the SMAS to tighten things up.
Roll.
We can plicate it, which means folding it onto itself to create a lift.
Can we combine those with platysma procedures?
Absolutely. Combining them gives you the best neck contouring.
Now let's talk about fat grafting for neck rejuvenation.
We often focus on getting rid of fat, but fat grafting can actually be great for adding volume back and making the contour look better.
Where in the neck and face might we use fat grafting?
Temples, cheeks, jawline, all those areas can be augmented to create a more youthful look.
Can we use it to fix contour problems from previous procedures?
Yeah, we can fill in those depressions or hollows that might be there.
But we have to remember that.
Fat grafting might take a few sessions to get the results we want. We need to be upfront with the patient about that.
Let's talk about skin resurfacing for neck rejuvenation.
Skin resurfacing, like lasers or chemical peels, can make the skin look smoother and more even-toned.
Okay.
It gets rid of wrinkles and age spots.
When might we do skin resurfacing?
It can be done on its own or with a neck lift to make the results even better.
What's important when choosing a skin resurfacing method?
The patient's skin type and what they need.
Okay, let's talk about how technology is being used in neck rejuvenation.
Technology is changing things all the time. It's giving us new tools to work with.
Can you give us some examples?
Sure. Minimally invasive techniques that use radiofrequency or ultrasound energy can tighten the skin without having to do a big surgery.
And those minimally invasive techniques, what are the benefits?
Quicker recovery, fewer complications. That's why patients like them.
And it's always changing.
Absolutely. New devices and approaches are coming out all the time, which makes minimally invasive neck rejuvenation really exciting.
Okay, what else is trending?
We're seeing more personalized treatment plans.
Okay, what does that mean for the patient?
It means we recognize that everyone is different. So we tailor our approach to their specific concerns and anatomy.
And that personalized approach leads to?
Better results and happier patients.
What about combining surgical and non-surgical techniques?
That's definitely gaining popularity. Combining things lets us get the best possible rejuvenation.
For example?
The patient might have a limited neck lift, plus laser skin resurfacing and injectables to tackle multiple signs of aging at the same time.
Okay, so that multimodal approach helps us to...
Get a more natural result.
Okay, so what's next for neck rejuvenation surgery?
Who knows? But as technology keeps advancing, I think we'll see even less invasive techniques, faster recovery times, and more precision.
What about stem cell therapy and regenerative medicine?
That's definitely something to keep an eye on. It could really change how we rejuvenate tissues. Imagine long-lasting results.
And artificial intelligence, machine learning.
Those are probably going to play a bigger and bigger role in planning and doing surgery. They'll make us even more accurate and predictable.
Okay, so the future of neck rejuvenation surgery is...
Looking bright. We're going to keep seeing new ideas and techniques that will make things better for our patients.
Okay, now let's focus on a specific aspect of neck rejuvenation. managing the submandibular glands.
Okay. Those glands can droop with age, creating a bulge under the jawline.
And we need to fix that during surgery.
Often, yes, if you want a really good result.
Okay, what are our options?
We have a few different approaches. Each one has its pros and cons.
Right.
We could take out part or all of the gland. That's called submandibular gland resection.
Okay, that gets rid of the bulge, but
It has risks. You could injure the marginal mandibular nerve or the lingual nerve. That could cause problems for the patient.
what about just moving it up?
You mean submandibular gland suspension?
Yeah.
That's when we suture the gland higher up. It gets better support and isn't as prominent.
How does that compare to resection?
It's less invasive, but might not work as well if the ptosis is really bad.
And what about botulinum toxin?
You can inject it into the gland to make it smaller.
How does that work?
It reduces its function so it doesn't bulge as much.
So it's
Minimally invasive with fewer risks, but you have to keep doing the injections.
okay. How do we choose which technique to use?
It depends on how bad the ptosis is, the anatomy, and what the surgeon prefers.
And it's really important too.
Talk to the patient about the risks and benefits of each option,
Okay.
and make a decision together based on what they need and want.
Now, let's discuss the digastric muscles.
Okay. Those muscles are under the jawline. They can make a double chin or fullness in the upper neck.
And if we address those during surgery,
You can make the neck and jawline look even better.
okay. How do we manage the digastric muscles?
We can take out part of the anterior belly.
Okay, and what does that involve?
We just remove a piece of the muscle to make it less bulky and give it more definition.
And what about suspension?
We could do that too. We stitch the muscles higher up to give them support.
So both of those techniques can.
Make the digastric muscles less prominent.
And how do we choose between them?
It depends on the patient's anatomy and what the surgeon prefers.
What's important to remember about working with these muscles?
You can affect swallowing if you're not careful, so be meticulous with your technique and watch them closely after surgery.
Okay. Now let's talk about scar management.
Scars are going to happen, but we can minimize them with good technique and good post-op care.
Okay. What can we do during surgery to minimize scarring?
Use fine sutures and close the incisions carefully to reduce tension.
And post-op,
Give them clear instructions on how to take care of the wounds.
like.
Keep the incisions clean and dry, use ointments, and stay out of the sun.
What about scar products?
We might recommend silicone gel sheeting or something similar to help flatten and soften the scars.
Okay. And if they get hypertrophic or keloid scarring,
We need to act quickly.
what do we do?
Steroid injections or laser therapy can really help.
What else is important?
Talk to them about their concerns about scarring and be realistic about how long it takes for scars to mature.
Okay. Let's discuss patient education.
Communication is key. You need a good relationship with your patient.
Why is that so important?
It keeps patients happy. And it's important for good outcomes.
What do we need to tell them?
Everything about the procedure, what it does, what the risks are, what the alternatives are,
Okay.
and let them ask questions. Let them be part of the decision-making process.
What other resources can we give them?
We can give them brochures, point them to websites, or tell them about support groups.
Okay.
All those things can help them learn more and feel more at ease.
So if we make sure our patients are well informed.
They'll feel more confident about their decision to have neck rejuvenation.
Now, let's touch on the psychological aspects of neck rejuvenation surgery.
We need to understand why the patient wants surgery and what they expect.
Why?
We have to make sure they're doing it for the right reasons and that their expectations are reasonable.
What else do we need to talk about?
If they have any psychological issues or body image concerns, we need to address those.
What about body dysmorphic disorder?
We have to be on the lookout for that. It's
Okay.
when people are overly focused on flaws in their appearance.
And if we think a patient might have it,
They need to see a psychologist.
let's talk about the role of photography in neck rejuvenation surgery.
Pre-op photos are really important.
Heard.
Seeing what the patient looked like before, planning the surgery, and seeing how well it worked.
What kinds of pictures do we take?
Standardized photos from different angles so you can see the neck's contours, the skin texture, and whatever the patient is concerned about.
And post-op.
We take pictures regularly to track how they're healing and how the results are developing.
Okay. And how do we use those pictures?
We compare the before and afters
To do what?
to see if the surgery worked and to make adjustments if we need to.
So it's important to take good, consistent photos.
Absolutely. For our records, for communicating with the patient, and for research.
Okay. Now let's focus on the platysma muscle.
The platysma is key in how the neck looks. If it's saggy or banded, we need to fix it.
Okay. What are some techniques for managing the platysma?
Platysmoplasty. That's a common one.
Okay.
We manipulate the muscle. Could be plication, suspension, or resection.
Can you explain those?
Sure. Platation is folding the muscle on itself to tighten and shorten it. Suspension is stitching it higher up for support. And resection is taking out a piece of the muscle to make it smaller.
Okay. How do we decide which technique to use?
It depends on how loose it is, if there's banding, and what the surgeon prefers.
What do we need to be careful of when we're working with the platysma?
If you tighten it too much, it'll look unnatural, and the patient might not be able to move their neck properly.
So we need to.
Be very precise and know the anatomy really well.
Okay. Let's talk about the jowls.
Jowls are that sagging along the jawline.
Yeah.
It's a classic sign of aging.
Okay. How do we fix that surgically?
Usually a combination of things. Tighten the skin, remove some fat, and work with the SMAS and platysma.
Okay. And what about liposuction?
That can help to get rid of extra fat in the jowls.
Okay. And what about tightening the skin?
A facelift or a neck lift can lift and reposition that sagging skin.
And the SMAS and platysma?
We can do things like plication or suspension to give them more support and shape.
So the goal is to...
Create a nice, smooth jawline that blends in with the neck.
And what do we need to avoid?
Over-tightening. It'll look weird like they're in a wind tunnel.
Okay. Let's talk about procedures that can enhance the results of neck rejuvenation surgery.
Okay. A neck lift can fix a lot of things, but sometimes we can combine it with other procedures to get even better results.
Can you give us some examples?
Sure. If the patient has a lot of loose skin, they might also benefit from a brow lift or eyelid surgery.
Why would we do those?
It takes care of the sagging in the upper face. It creates a more balanced, youthful look.
What if the patient has lost volume in their face?
We can use fat grafting or fillers to plump things up.
And if they have sun damage or wrinkles?
You can use laser skin resurfacing or chemical peels. It'll improve the skin's texture and tone.
Okay. So if we carefully choose and sequence those additional procedures...
We can really maximize the results and keep our patients happy.
Okay. Let's talk about the importance of a multidisciplinary approach to neck rejuvenation.
We can't do it all alone.
What do you mean?
Sometimes we need to work with other specialists to get the best results.
Like who?
A dermatologist for skin resurfacing or if they have a skin condition.
Okay. What if there's a dental problem?
Then we might need to bring in a dentist or an oral surgeon.
To fix.
Jaw alignment or any dental issues.
And what about psychological concerns?
A psychologist might be helpful if the patient has body image issues or if their mental health is a factor in why they want surgery.
So this team approach ensures that.
The patient gets comprehensive care and the best treatment for your individual needs.
Okay, let's talk about long-term follow-up after neck rejuvenation.
To keep those results looking good, we need to stay involved.
Okay, so what's the point of those follow-up appointments?
We can see how they're healing, answer any questions they have, and make adjustments if we need to.
And what about lifestyle?
Super important. We tell them to stay out of the sun, eat healthy, and exercise.
Why?
It helps them maintain those results.
Okay, and we can't stop aging.
Nope. They might need touch-ups or non-surgical treatments as time goes on.
Okay, so by providing good long-term care.
We make sure our patients get the most out of their surgery.
Now let's talk about how neck rejuvenation surgery techniques have evolved over time.
In the early days, neck lifts were all about cutting out skin.
And what was wrong with that?
It looked tight and unnatural.
So what's changed?
We understand neck anatomy and aging better now, so our techniques have gotten better too.
What do modern neck lifts address?
They fix loose skin, but they also deal with muscle laxity, fat, and the ligaments.
So now we get...
Results that look more natural and last longer.
And what about minimally invasive techniques?
They're getting more and more popular. Patients like them because they recover faster and have fewer problems.
And things keep changing.
Absolutely. Research and innovation are always happening. We keep finding better ways to get good results for our patients.
Okay, let's touch on something important. Choosing a good plastic surgeon.
Absolutely. Neck lift surgery isn't easy.
Yeah.
You need the right training, skills, and experience.
What should patients look for in a surgeon?
Board certification, good knowledge of neck anatomy and aging, and experience with the latest techniques.
What else?
Don't be afraid to ask questions.
About?
Their experience, their qualifications, and how they do neck rejuvenation.
So choosing the right surgeon is key too.
Getting the best results and minimizing risks.
Okay. Now let's talk about patient education again. It's so important.
It really is. We need to give patients the information they need to make good decisions.
What kind of information?
Everything about the procedure, what are the benefits, what are the risks, what else could we do?
Okay.
And we should encourage them to ask questions, let them be part of the decision.
Okay. What other resources can we give them?
Brochures, websites, support groups.
All those things can help.
Absolutely. It helps them learn more and feel better about their decision.
Okay. So when we make sure patients are well informed,
They can make the best choice for themselves and feel good about it.
to wrap up this deep dive, let's just emphasize one thing.
What's that?
You have to have a rock-solid understanding of neck anatomy, aging, and surgical techniques.
Yeah,
That's how you're going to succeed in this field.
couldn't agree more.
Thorough patient assessments, meticulous planning, and, of course, executing that plan perfectly.
Right.
And then attentive post-op care.
All of that. Those are the cornerstones of getting great results in neck rejuvenation surgery.
Absolutely. And remember, this deep dive is just the beginning.
Yeah. Keep hitting those books. Keep going to those review courses. Then learn from the pros.
Absolutely. That's the best way to really deepen your knowledge.
For sure.
Best of luck on your board exam.
You got this.